Sudhir, can we start?
We can, sir.
අපි අනිත් අය they can listen නේද? මේ uh, later on, no? Yeah. So share the screen. මේ Sudhir, අපි will ask everyone to on the cams නේද? It will be easy then.
Yes, sir. We'll ask everyone to turn on the cameras and interact with you.
Yeah. If not, this will not be productive. Ne? It will be more productive actually. Yeah. So we'll start. Anybody all did the first question? So yeah, it is quite a bit of a tricky question actually. Ne? So yeah, I assume that you all have read the question. So any volunteer can answer the first question. Api Lakmal gang have the Lakmal.
Yes, sir.
What do you think?
So it's Guillain-Barré syndrome. So
Excellent. Yes.
I can either, like usually I can do a nerve conduction study and see the it's slowing because of the demyelination. If not, also MRI might also show the nerve root enhancement, but nerve conduction study would be the better option rather than.
You think nerve conduction study is the preferred choice? Yes, actually, anybody has a different answer. Because this is a very this can, I mean, somebody can answer as what do you call CSF. I mean, just okay. We'll assume that this says the next question will be a CSF viral like a natua. This will be CSF proteins. Lakmal, what will your answer then be? CSF proteins.
Again, sir, because it's just 3 days.
Excellent.
Again, would be negative. Like usually.
Yeah, because it takes at least about 10 days to protein to be appear. But saying that for what you call the nerve conduction studies to be positive was it doesn't take very soon. That is why in Guillain-Barré syndrome they repeat it. If the first nerve conduction test is normal, they kind of repeat it again. Because sometimes it can be missed, but obviously there will be no proteins at all during the first week. So I have just put a small set of things about Guillain-Barré syndrome. I think we have discussed the same slide before as well. So I mean, just to refresh your memories, you need to know. I'll just tell only the MCQ points. You have to just to know you need to know the causes. The commonest cause is what? The most important cause.
The Campylobacter jejuni.
Campylobacter jejuni, which can follow diarrheal illness. Apart from that, there are these influenzas, HIV is important, Epstein-Barr virus, and even there were case reports during COVID time. It started on after COVID vaccine, they developed people developing this thing, but it was not well established. But after that, this concept of vaccine-induced Guillain-Barré got very popular, especially for meningococcal and H1N1 viruses. So just remember, they can ask that in your MCQ as well. So the clinical picture, I think you all know, even from the diagnostic criteria. And you will have to know about Miller-Fisher syndrome, which is a triad of ophthalmoplegia, ataxia, and areflexia. Next thing is their complications. This thing they are very fond of asking about the symptoms, especially you have to know apart now. We know about respiratory symptoms, we know about the weakness, we know about the facial weakness, but there can also be paresthesia, sensory involvement as well. You call it asthma. There are different variants as well. And then, I mean, I have told this before. So almost all the patients with Guillain-Barré syndrome I have seen, they complain of back pain. They ask for MCQs as well because back pain is due to nerve root inflammation, and also they have dysautonomic symptoms, which can be even the cause of. It is actually the commonest cause of death in Guillain-Barré syndrome because they can have sudden blood pressure fluctuations, and when their blood pressure goes down or their heart rate goes down, it converts into a tachyarrhythmia and all that. So it is the commonest cause for mortality as well. So these things you should know. And if you, I added a few slides. Yeah, I will give the last week. Did I give you the note actually? I can't remember. No, ne? Or did I give? I generally give it. I'm not sure. Oh, never mind. So this note I will give it because I added some points. Now in order to diagnose, it is basically more or less clinically you have to diagnose based on acute onset of progression and symmetrical involvement and absent reflexes. And generally, it peaks in about 1 month only. It peaks. So your diagnosis, just as Lakmal said, CSF, there will be albuminocytologic dissociation, which means that there is proteins without cells. The cells count will be less than 5. You have to know that count as well, less than 5. And then you have to know what you find. They ask in MCQs the nerve conduction studies. So just remember the term. They will have prolonged or absent F waves and absent H waves. This reflects demyelination process going on. You don't have to know what H wave, what F wave is, even I don't know. So just these are neurological nerve conduction wave patterns actually. They will be there. And if you're doing an antibody test, GQ1B antibody is of course not very specific. And then if you're doing, there is a place for MRI when there is back pain to look for, especially there can be this cord equinus and all that. If you want to look that, you have to see that. So those are the things they can ask related to Guillain-Barré syndrome in your question. So what is the management? Management, any place for steroids?
No, sir.
Yeah, that is also a very common question. Steroids, no place. The drug of choice will be?
IVIG or plasmapheresis.
Very good. Plasmapheresis or IVIG. And that again another MCQ is there that they tend to ask whether IVIG is better than plasmapheresis.
No difference.
Very good. Trials have shown it is equal. We'll move on to the next question. Yeah, this can be again. Now this question can be a challenging question because I'll tell you all why. It can be an interesting question. Anybody want to volunteer? SR.
Sir, I choose answer D.
You are thinking it's intramuscular vitamin B12, right?
No.
Anything else?
Answer D, sir. Initiate methotrexate.
Sorry, wait, what?
Second question, right? CC.
Yeah, second question. You want to wait? Are we in the same this thing? I think you are referring to question 3, ne? The question 2.
Yeah. A.
Oral folic acid. Anyone has a different answer?
No, sir. B. Sorry.
Okay, B. So what is your diagnosis here?
B12 deficiency.
Okay, what is the problem in B12 deficiency? Okay, why you are
Peripheral
100% sure?
neuropathy.
Very good. So the point here is, now you have to remember when you're treating macrocytic anemia, this can be very tricky. If the patient is having only if patient is having B12 deficiency and you're giving folate only, what will happen? It's a very common MCQ point again.
Neurological symptoms will worsen.
Will worsen. Why? Because of this metabolism, right? Now you can see the slides here. As Lakmal said, now what happens now in a patient who's having we'll assume that having a mild B12 deficiency and you're only treating with folate, what we'll do is you will convert the folate into tetrahydroxyfluoric acid, and by that you will convert the homocysteine into methionine and finish the B12 store. As a result, they are worsening, their spinal their neurological symptoms basically will be worsened. More importantly, if they are having a subacute combined degeneration, that will increase and patients will go into permanent paralysis even. So it is important. And so answer here is what?
Intramuscular.
Yeah, intramuscular, you have to give intramuscular because now why? As you all said that the patient is having cognitive slowing and occasional paresthesia. So that means you can assume that this is B12 deficiency. And yes, I know that I told you all before that generally in B12 deficiency, MCV gets extremely high. More than 120, you have to consider vitamin B12 deficiency. But then I also said it's not a hard and fast rule as well. So then you have the pancytopenia in B12 deficiency as well, and they can show hypersegmented neutrophils with low vitamin B12. Some important things around this area in your exam wise, what they can ask is the concept that I just now discussed, and also B12 deficiency, they intramuscular doses every other day for 6 days, 6 doses they give, and after that every 3 months. So what happens? The reticulocyte count, these things you should know by heart. Reticulocyte count peaks by 5 to 10 days. The hemoglobin level rises 1 gram every week, even for iron deficiency anemia as well. And sensory neuropathy, it takes about 6 to 12 months to correct. But especially spinal damage, it takes a long time. Sometimes it is even irreversible to correct. So those things they can ask in the exam. Right. So I think the third question already answered, ne? SR one SR. I think you answered already.
I chose initiate methotrexate there.
Yeah, anyone has a different answer? No. So because if it was when we were medical students, what we were told was to start with NSAIDs first, but then it changed from the guideline itself, the EULA guideline. So this is from some information from the now okay. And another important thing about this now, what is this patient's diagnosis?
Rheumatoid arthritis.
Are you sure it is rheumatoid? Because rheumatoid factor is negative.
But anti-CCP is strongly positive.
Excellent. Yes, very good. Because early on they said that this is seronegative arthritis, but their definitions change, and now this is classical rheumatoid arthritis. So rheumatoid arthritis, you have to know about the management. A bit of you have to know. They can ask the drugs they can give and the criteria. Criteria, of course, I think nothing big about the criteria. There are joint involvement. They give points if more than 6 of 10 definite rheumatoid arthritis. Now just imagine if more than 10 joints are involved, you get 5 marks. With a positive test something, you can diagnose. So like that, there are these tests, you can read it up, and then generally the duration is more than 6 weeks. So with that, you can diagnose rheumatoid arthritis, and their algorithm is important. So always they start with methotrexate. That will be the drug of choice to start. If by any chance there are contraindications to methotrexate, anyone can name contraindications to methotrexate? That also they ask.
Active liver disease.
Increased
Yes.
liver enzymes.
Very good.
Pregnancy.
Pregnancy, of no way to give.
Pancytopenia.
Pancytopenia, yes, very good. So pancytopenia, there's a methotrexate, and obviously if there's an infection, you tend to avoid methotrexate as well. So if by any chance methotrexate is contraindicated, then that drug you also should know that will be leflunomide and sulfasalazine, right? So you can start, and obviously once you start either with methotrexate, which is a first line drug, you will not straight away start with corticosteroids, but it depends. Generally, what rheumatologists do is they give a short course of corticosteroids because their improvement will quickly kind of increase than without corticosteroids, and after that they tail it off after about 3 to 6 months. They tail it off, and then there are these new drugs that people like asking. That will be the I hope you can see here. If by any chance these patients they do not respond to the initial therapy after about 6 months, and then you have to see then you can add the second disease modifying anti-inflammatory drug, or the newest drug is to add the JAK inhibitors. And just remember the name JAK inhibitors. And also I think another important point here is the poor prognostic factors. That also they love asking about poor prognostic factors. So high levels of rheumatoid factor is a known poor prognostic factor. High disease activity and very high amount of joints are involved. And other thing is if you cannot control with even with 2 disease modifying anti-inflammatory drugs, it is high risk patient. So these things will more fail. They're more prone to not respond to treatment than to respond to treatment. So yeah.
So if the patient is presenting acutely symptomatic as the first presentation, then we'll have to start NSAIDs or steroids, right?
Yeah.
So in that,
Because
do we start DMARDs with them, or do we wait till the acute flare up?
very good. Excellent question. Yeah, you're thinking outside the box. Now, if the patient is coming, you mean a previously undiagnosed patient, right?
Yes, sir.
Yeah, so undiagnosed patient coming with acute onset of this thing, you have to first thing you should exclude the arthritis which can cause acutely, such as gout or septic arthritis or there are many other causes. You have to exclude that cause. You will not diagnose that rheumatoid arthritis actually. That is why the term has come seropositive arthritis. So you will just initially you will manage with steroids actually. You will not start with DMARDs until you confirm. But if now imagine someone is coming with about 2-3 weeks duration. This is a practical point. They will not ask for MCQ. If someone comes the 2-3 week history of symmetrical joint arthritis, young female, classical symptoms are there, rheumatoid factor positive, anti-CCP positive, then of course you'll be starting with the disease modifying drug straight away. If you start with methotrexate, it's a case to case basis one. But acute onset one, there is no place because you have to confirm the criteria. You have to take 6 months. But if the joint involvement is very classical and it is more than this thing, you have to start. Yeah. Then next one is of course I think it's a simple question for you all. කවුරුහරි කියනවා මම එහෙම point out කරන්න ඕන සුලක්කනා.
Sir, I think it's A, start oral doxycycline and discharge.
Anybody else? Any different answer from anybody?
IV ceftriaxone and monitor renal function.
Yes. So Surakana, now to read the question, this is obviously I think you all would have come up with the diagnosis leptospirosis, right? This is classical leptospirosis coming with rural area, fibromyalgia, all the conjunctival suffusion. There's muscle pain, dark urine, you reduce urine output, and of course you can see there is a low platelet with a high WBC, creatinine and liver both dearranged, right? So that indicates that patient is having this thing. So in mild form of leptospirosis, yes, there is a place to treat with doxycycline. Mild leptospirosis, which is like platelet is not very low, patients who has a good appetite and no organ involvement. But the person who is having organ involvement, you definitely have to give IV ceftriaxone, which is the drug of choice, and you have to obviously monitor the renal function test, right? Any other differential diagnosis anyone can give here? Why can't this be dengue? Dengue because WBC is 14, right? Dengue WBC will go low. Any other possibility here is coming from a rural area, coming with fibromyalgia. Of course, all the features are not there. This you have to think about scrub typhus here as well. But the liver involvement is not classic. So leptospirosis, there are things that they ask in the MCQ. One thing is the incubation period, 10 to 14 days. That's why, because trip again 2 weeks trip you can get this thing. So there are phases. Now they categorize as basically the bacteremic phase and the leptospiruric phase. In the bacteremic phase only you get all the fevers and all that. Leptospiruric is the ones who they get, but once they excrete the organism from urine. But generally the two phases you can't define clinically, you can't differentiate clinically. So you need to know the clinical features, and then you have to know about Wales disease. Wales disease is when they develop liver failure, about 10% like they develop into that. And their general features are I mean, I will tell you the important MCQ wise ones. Other things you can read. Apart from the liver failure, they can quite commonly they get hepatic encephalopathy with the liver failure, and even they can get uremic encephalopathy as well. Other thing is they from MCQs they ask about the renal failure one. You see now this question also they are asking about renal failure. What type of renal failures they can get? They can get acute interstitial nephritis or acute tubular necrosis. Both ones they can get. And special thing about their renal failure is they have oligouric renal failure, and also they can have hypokalemic renal failure. That is a different one, because generally the renal failures we know acute renal failures they are hypokalemic uh, and and anuric renal failures, right? And then, of course, they can ask about this pulmonary hemorrhage. It's a very known devastating complication. Can anyone tell what is the management for these pulmonary hemorrhages? They ask that also. So pulmonary hemorrhages management will be IV methylprednisolone and also or plasmapheresis. Either one, but you don't generally give both. And then, of course, other common complications we see is myocarditis and aseptic meningitis. It is also quite common. They ask in MCQ as well. Right. Fifth question. Any thoughts? Api Lakshika again, Lakshika. Lakshika, where is Gihila? Lakshman, what do you think?
Lung abscess.
Lung abscess. Why? I mean, it's classical, right? So there are two possibilities if a patient like this comes after pneumonia. If they come with fever after a couple of weeks, with clubbing and swinging fever and foul smelling sputum with weight loss, two possibilities. One thing is a empyema, and either it can be empyema or a lung abscess. So here, why it's not empyema? Because there is extra shows persistent right side lower lobe opacity. But if there was a with the air fluid level, it's giving you the question itself. But if there was a pericardial effusion with this picture, you have to think about empyema here, right? Other thing is they can have if they're present with shortness of breath, you have to think about a parapneumonic effusion extending later on, but they will not have increased fever, they will not have clubbing, they can't have foul smelling sputum at all that. So lung abscess you have to remember. Right, we'll move on to the next MCQ. MCQ also these are not very difficult. Either these are type of on and off you can get MCQs like this. So if you can do this, you will definitely pass the exam. Yeah, we'll go. Amoebic colitis. Taridu Lakmal. Yeah, Taridu. Tell the whole.
BCT, true.
You think colonoscopy is contraindicated?
I
True or
didn't get
false?
the answer.
You didn't answer that, right? Okay. Hepatic abscess is a complication. Second one.
It is true.
Okay. Guess next one. CD.
CD also true.
CD true. Okay. So good. You have answered pretty well. But colonoscopy generally it's contraindicated because colonoscopy එකක් කරන්න බෑ. Flexisigmoidoscopy එකක් දාගන්න පුළුවන් මේ, but you very dangerous. Colonoscopy of course no chance, because why? They are hugely inflamed colon, and if you put a colonoscope you are going to perforate the colon. So it is contraindicated actually in this thing. So amoebiasis was a few words, because if the question paper is coming from just now, you will definitely have a question if question about amoebiasis, because there's one of the consultants over there who is fond of amoebiasis and he's doing all the researches. He is the one who always asks about amoeba. So few words for the MCQ. Amoeba is caused by Entamoeba histolytica, and it is generally the cecum is the infection. It is by contaminated water or food or whatever it is, and they are their classical thing about amoebiasis is you get the flask-shaped broad-based ulcers. And these ulcers generally are in the mucous or submucous areas, and they are the ones who can rupture easily. And how you diagnose is by stool microscopy. Rarely they do the NAT, but in Sri Lanka they don't do that much. And another thing is in stools, if you look for cyst, is the one you're going to look for, and tropocytes as well. So that was in one MCQ. I think one of your past MCQs they have asked. Cysts are typically found in formed stools. But if you want to see tropocytes will be in loose stools, so in the diarrhea. It was asked once. No? And other form of investigation is you can take a biopsy, but biopsy is not recommended in the acute stage, which is very dangerous. So treatment will be metronidazole for 10 days. But if there's an amoebic liver abscess, you can get you have to continue for about 6 weeks. So the question, if you all get for SBA about amoebiasis, they will tell some guy who's drinking what? Takmal?
Drinking.
Toddy. Especially with toddy or a kalawal like a pallunata passe, there can be amoebiasis there. That's why these toddy drinkers actually they present even. Actually, person coming after months, because initial they have subclinical infection and straight away they come with present with the liver abscess as well. So liver abscess can be quite challenging to treat because antibiotic penetrate karanit nahi, so you have to aspirate it as well. Some patients, the abscess becomes so severe you need surgery also. So it can be quite devastating. And rarely there can be intestinal perforations, can be the life-threatening complication here. Right. So any questions from that?
Yes, sir. Even if it is not fulminant, is colonoscopy contraindicated, sir? Because sometimes they
Yes.
diagnose with biopsy, right? Like we
That,
see
yeah.
the pulse ulcer and all that.
Yeah. Thing
Like
is,
if the peritoneal signs are there and all that, we won't do the colonoscopy because of the rupture and we saw the rupture. But if the patient is just presenting with diarrhea and mucousy diarrhea for a long time, for 2 weeks, then we'll anyways be doing with the investigation, we might do a colonoscopy to
I
rule
do
out.
colonoscopy. Yes, if they are diarrhea, it is indicated. But if amoebic colitis is there, you cannot do the colonoscopy, because colitis means your colon is already inflamed. But if you are just having amoebiasis, just a few diarrhea, I mean no blood and mucus diarrhea, just normal diarrhea and all the GI symptoms, just can do. That's how you take the biopsies as well. But if not, you can't do. But actual point over here is, you don't need to do a colonoscopy for amoebic colitis. You had just, because it is generally amoebiasis, you can see in the cecum. Cecum and cecum. It's generally infection is in cecum, but the colitis is in the large colon. So you can plexisigmoidoscopy is generally enough. Actually, these biopsy samples, what they take is from the plexisigmoidoscopy. You don't tend to do a colonoscopy. Colonoscopy is a huge thing. You can't prepare for 3 days and do a colonoscopy. You can give 3 doses of this thing and prepare for colonoscopy in a amoebic colitis patient. But maybe there's a place in an amoebic infection. Yeah.
So the other thing, the gastric perforation is a complication. Do we get gastric perforation in amoebiasis? No, right?
Yes. Yes, it is very uncommon, extremely uncommon, but there are instances you have got. But I think, yeah, because as for MCQ, what they ask is, yeah, that's what I was going to discuss later on. For a MCQ, you don't generally kind of answer these rare things, because these are case report ones. So what is perforation is the intestinal perforation. Intestinal perforation is classical. Gastric perforation is extremely rare in case report things. So case report only things, generally you have to mark it as false in your exam. Yeah. Yeah, I didn't tell that. I didn't explain it to you. Yeah. Good. So up to there, it's fine. Yeah, so we'll go with dengue hemorrhagic fever. Now these are the questions may put practical aspect again. So Lakmal, you want to answer the next question? Yeah. So first, First one, loss of 10% HCT after fluid replacement indication of blood clot. මොකක්ද හිතන්නේ ඒක?
I'm not sure about this question, sir.
Anybody, any very diplomatic answer? Yeah, so we'll go by this is a tough question, right? So dengue hemorrhagic fever, if a patient is losing 10% of hematocrit after fluid replacement, is it an indication for this thing? It is false, because now how much of HCT drop will you expect after giving fluid? Anybody? Generally, from when you now, why do we give fluid actually in dengue hemorrhagic fever? Why do we give fluid is now we want that there. Now I will tell you the theory, right? So why you give fluid is when there is see this slide. Now this is the whole course of dengue hemorrhagic fever. Now when fever happens, there becomes inflammation in the capillary wall, and then fluid starts leaking out. So when the fluid especially they leak into your abdomen and the lung. So what happens when the fluid leaks? The hematocrit keeps on rising when the fluid leaks, and there becomes one point the body can't compensate. Now fluid keeps on leaking, the body can't compensate, and he can't maintain the perfusion. Just before that point, you call that as pre-shock, and just when the body gives it up, you call that dengue shock. So what happens is, if the shock keeps on persisting, the body will go into an irreversible shock state, and you cannot recover from that. That's why people die from dengue. And on the other hand, what you need to do is, when you're managing dengue, especially if the patient is leaking, have gone to dengue hemorrhagic fever leaking, what you have to do is you have to manage the fluid leaking. You have to give blood according to the fluid leak. You have to make it equal. So if you don't give the blood at the same rate that it's leaking, what happens is patient will be in shock. But at the same time, if you give fluid more than the leaking phase, patient will be on heart failure and fluid overload. So both instances are causes for mortality in dengue. And so how we can't really see the fluid leaking. We can't see from a scan. We can't do anything. So only way we can see it is by urine output, blood pressure, pulse pressure, heart rate, and the hematocrit. By these parameters, we assume now this patient is leaking fast or leaking slow. So generally what happens is, can I give me 1 minute? I have to get this call from the hospital. Give me a second. Yeah, hi. Sorry about it. So yeah, now I was telling, yeah. So now, other thing is what happens in dengue. Now, just now I told you this phenomenon that patients are leaking, and at the same time we know that they have platelet dysfunction, and their platelet levels are extremely low. So what happens as a tendency, patients start bleeding. So then there can be patients can, now this makes things more complicated, and it complicates the whole picture so much, very difficult to manage. So now at a time patients start bleeding, then what will happen to the hematocrit when they are bleeding? Hematocrit will go down, right? So now, by any chance, we'll imagine if the patient becomes unstable in the sense low urine output, low pulse pressure, low tachycardia, and patient is very ill looking, but the hematocrit is normal. Can someone tell me what does that mean?
Internal bleeding.
Yes, but if it's bleeding, the hematocrit can't be normal, right? Hematocrit should go low. That means what? Lakmal, can tell, or anybody? Give me a second. Yeah, that means, sorry, that means there is both leaking. Now, this can be asked in MCQs, even in your vivas also they ask this. I mean, this emergency vivas. That means there is both leaking and bleeding both together, right? So both leaking and bleeding both together, that's why the hematocrit is normal. So generally, there is no percentage. If the hematocrit by generally you don't calculate percentages in a practical setting, because hematocrit you only instance you talk about percentage is 20% of the hematocrit. That means if there's a 20% rise of the hematocrit, you have to suspect there is leaking. But there is no rule that if there is a hematocrit drop in 10% or 20%, there is bleeding. Hematocrit drop, it implies bleeding, and you have to correlate clinically. That's what I explained about it. So the answer to the first question is loss of 10% hematocrit after fluid replacement is an indication for blood transfusion. You can't always tell that. Yes, it can be true, but that doesn't mean that you have to give blood always, just because after you give fluid, because especially after you give a bolus of fluid, you expect the hematocrit to drop from 6 to 10 points from their normal level. And I think so there is nothing called percentage, so it is wrong. So that is why you give fluid also to reduce the hematocrit, right? Any questions from that? We'll go step by step, because this is very tough. Any questions? Right, okay. So then next question they're asking is, now initial fluid replacement is by dextran. Obviously, I think in how the answer to the question, I can't remember. Lakshika, මොකද හිතන්නේ? Second step. Lakmal ගෙන් තමයි දැනන්නේ.
False, right?
False.
No.
Obviously, it's a this thing. So, I mean, this is from the Sri Lankan guideline. They kind of ask questions like this. Now, if the patient is coming with decompensated shock or profound shock, I mean, what is the definition of? You should know these definitions of these shocks, right? Now, pre-sweating, pre-shock කියන්නේ, their patient will be having abdominal pain, sweating, vomiting, low urine output less than 0.5 milligrams per kilogram per hour, or capillary filling time more than 2 with a postural drop more than 20. You have to suspect pre-shock. And if the patient is having coming with what you call increase patients are unstable in dengue and they have a pulse pressure less than 20, then you have to think about patient is having compensated shock, because they are now that what I told, now body is compensating them. So what happens when the blood pressure goes less than 90/60? Then you call it as decompensated shock. And if by any chance the blood pressure is unrecordable, you call it as profound shock. Right? Those terms are important in dengue management because they are monitoring and all these things also change. So now, by any chance, we think the patient is coming with this. These patients come to the hospital frequently. Suddenly come with collapse, no recordable pulse. Dextran didi inne naha. What you do is you give rapid bolus of fluid until the blood pressure is recordable. And while after the blood pressure is recordable, then you have to make sure the pulse pressure is more than 25 or less than 25. If the pulse pressure has gone up, then of course you have to slowly tail the fluid off, just like what we give 100, 500, 350, 450, 400, 300, 100. Like we can give on based on the urine output and the hematocrit. By any chance, if you imagine you give a fluid bolus and patient's pulse pressure is not improved, it is less than 25, then you have to do a hematocrit. After you do the hematocrit, you have to see whether hematocrit is high or low or normal. So if the hematocrit is high from the baseline, then of course you can give the second dose, because now that means මොකද patient ගේ තාම leak වෙනවා වැඩි, more leaking, that's why the hematocrit is high. So you give the second crystalloid bolus 10 ml per kilogram over 1 hour, maximum 500. All the dengue calculations are for 50 kilograms, right? And then what happens is you repeat it. After the second bolus, you repeat it. Then you do the hematocrit. If the hematocrit is still high, after the second bolus only, you have to give IV dextran, IV colloids or dextran. Dextran is being given 50 ml per kilogram over 1 hour. You have to know the dose. You have to know when it will be given. So after 2 boluses, only you have to give dextran. Is it clear? Yeah. So fluid replacement is 50 kilogram person, critical phase is 406. So this is true because I have put a calculation here as well. This is the what are they asking the question? Fluid replacement in the critical phase, yeah. So in the critical phase, it will be yeah, it's it. So critical phase, it will be maintenance plus 5% of deficit. Maintenance or pediatric, well, I think they would have thought you pediatric thing. So you are calculating the normal fashion, the first 10 100 ml per kilogram, then second 10 50 ml per kilogram, and then the last next 20 up to 50 max, it will be 20 ml per kilogram. So if you calculate all together, that is 2100 ml. Then the 5% deficit is being calculated generally by 50 ml per kilogram is 5%. Is found out that 50 ml per kilogram is 5% of deficit. So if the patient is 50 kilos, that is 2500. So altogether, if you take both into account, it will be 4600, right? So 4600 fluid per day. Sometimes we just don't take 4600. For our ease, we make it 5000 per day, right? Sometimes. So that is how you calculate the critical phase fluid. Now, critical phase fluid, I'll just tell you something, another important thing. You can't give critical phase fluid in a uniform fashion. Now just imagine, now we'll go to this chart. Patient leaks like this. So 48 hours leaking phase, we have a leak. Put a bit of fluid then the band in a constant rate. So our fluid requirement will also go like this, go up and come down. So we have to adjust according to the urine output and blood pressure. HCT bala, you have to reduce the whole. So because that is why the critical phase monitoring is very important, because you actually, I have not seen the chart, critical phase chart, because in the critical phase chart, they are monitoring totally changes. You have to try to measure the urine output hourly if catheterized, if not 3 hourly, blood pressure, pulse pressure, hematocrit done every hourly, and so every hourly parameters are taken into account to calculate the fluid. So urine output, so again, this question, next question is what I'm saying. It's false. Urine output cannot be maintained. I mean, should be maintained. Or what they're asking is urine output of 5. No. So at all time, it is false. At least this amount should be kept, but you can't maintain the same amount, right? It is wrong. So reduction of pulse pressure is an indication of compensated shock. So I just now told you all that pulse pressure less than 20 is a definition of compensated shock. So yeah, I think we covered a lot of concepts about dengue with that question. Any questions? No, right. Question number 3. Shall we change the question? Will cut the immune reaction thing. What indicates a renal biopsy? So I'm going to point out because no one is answering. Liony is there. Liony echo. Tilanya no Tilanya. Then Kaurut. Yeah. So I'll right. So the indications here, lupus nephritis, obviously beyond doubt, lupus nephritis, there are 6 classes. Everything about lupus nephritis is based on the renal biopsy. That is the utmost important thing in the renal biopsy. There is no contraindications as such. You have to do it. Good-Pasture syndrome. Good-Pasture syndrome also, you need to do a renal biopsy because there is a rapidly proliferating glomerulonephritis going on in Good-Pasture syndrome, and you need to, in order to diagnose this rapidly proliferating glomerulonephritis, you have to do a renal biopsy. If not, you can't diagnose. Diabetic nephropathy, it is not an indication for renal biopsy because you don't diagnose diabetic nephropathy with the renal biopsy. You can diagnose, but you don't do. If not, you have to do renal biopsies in all the diabetic patients. But they have specifically told, I think I have discussed this previously, specifically told instances where diabetic nephropathy patients may need a biopsy. Because why? A diabetic patient having renal impairment, if they have rapidly progressing renal disease, that means it can't be diabetic nephropathy. And if their diabetes is a recent onset one, that can't be diabetic. And that the third most important thing is, now when we were, I think even it shows also diabetic patient coming with renal impairment, we check for their fundus. If they have diabetic retinopathic changes, then we know that maybe this is diabetic nephropathy. But imagine a diabetic patient coming, there is no diabetic nephropathy, retinopathy, and there is renal impairment. So then it is very unlikely to be diabetic related nephropathy, because if you look at the pathogenesis of diabetes, it at least takes long-standing years for renal problems to occur. And initially, patients will have poor glycemic control. Then, in about 7-8 years, they can get retinopathy. Then, after about 10 years only, they will get nephropathy. So, generally, it is quite unusual for someone to develop diabetic nephropathy before diabetic retinopathy. So, it's a very good marker to do renal biopsies or not. Because if by any chance, if a diabetic patient coming with increased creatinine and there is no diabetic retinopathy, then we will do a renal biopsy. TB nephritis is a contraindication for renal biopsy because you can't do pointless doing this as well. Analgesic nephropathy. Did I discuss analgesic nephropathy with you guys? I'm not sure. So anyway, the analgesic nephropathy, you can do a renal biopsy, but it is not always indicated, but you can do. Right. So next question is also quite interesting question they can ask.
So last one, true or false?
Last one is
Analgesic.
what is indicated, you can do. Yes, true. But again, if there is a good clinical history, I'm just showing for your information. If there's a good clinical history, you don't do biopsy. If there's analgesic. So very easy. In rheumatic heart disease, can there be bronchial asthma?
So is this rheumatic heart disease or any rheumatic disease?
No, this sorry, not rheumatic heart disease. This is rheumatic. No, so sorry. We'll I'm changing the question. Sorry, rheumatoid arthritis. We'll change this as rheumatoid arthritis. Sorry. So rheumatoid arthritis, can it cause bronchial asthma?
No.
Yeah, it is not a direct correlation. What about fibrosing ambulitis?
True.
Very
Can
good.
cause.
Yes, it can cause in two mechanisms. One thing is when these rheumatoid arthritis patients are exposed to coal dust, they can develop a syndrome called Kaplan syndrome. Kaplan syndrome is a fibrosing alveolitis type, is interstitial lung disease. So rheumatoid arthritis can cause fibrosing alveolitis in that instance. You all are correct. And the second mechanism is most of these rheumatoid arthritis patients, they take methotrexate. So methotrexate per se can cause fibrosing alveolitis. So both mechanisms it can cause. Very good. Pleural effusions?
True.
Yeah, true. And also not only pleural, even pericardial effusions they can get, right? Even SLE patients, sometimes they present with cardiac tamponades. Pulmonary embolism? Very tricky one, eh? Very tricky one. I think I put a slide. Yeah. So I think pulmonary embolism generally directly don't cause by rheumatoid arthritis. It's not a direct thing. But if the question was SLE, yes, it is definitely true if it's SLE. But rheumatoid arthritis generally we don't, you don't get pulmonary embolisms per se. You don't even request pulmonary embolism screening in if they come with shortness of breath at the first instances. So it is false. What about pulmonary nodules?
True.
It is very good. It is true because just like rheumatoid nodules in the hand, you can get pulmonary nodules in the lungs. So I think I have listed the things which can cause, and I have also explained. And one more thing is, which is a very rare thing, is bronchiectasis. Bronchiectasis is, bronchiectasis is common, but rheumatoid arthritis patients developing bronchiectasis is extremely rare. It is not that common. And you all have to know, I have put in the note other systemic manifestations of rheumatoid arthritis. It is important that they ask these things, especially renal one they ask because you have to know membranous glomerulonephritis, amyloidosis, and even tubular interstitial nephritis. They can cause eye, of course, I think you all know scleritis, episcleritis, scleromalacia, perforons, keratoconjunctivitis, Zika, and GI, of course, nothing big to talk about. Neurological losses, they can get carpal tunnel syndromes and cervical myelopathies. Mononeuritis, of course, most of these diseases can cause. Cardiac, of course, I told tamponades and all that. Rest of things you all know. Right. Another important question, I think they will be asking a lot, and there are some new concepts that I want to talk is regarding statin. Causes myalgia, it is quite common, right? You call that statin-induced myopathy. Now, what happens is statins, they can increase the creatine phosphokinase level. They can cause muscle damage. And you generally don't stop based just because someone is having myalgia. So if in your practice also, if someone who's on statin comes and tell you they're having myalgia, you just ask to do a CPK. If the CPK is more than 3 times, then you have to stop statins. And if the CPK is more than 10 times, you have to stop statins. Do check for serum creatinine as well, because they can cause rhabdomyolysis. And extremely rare, even about less than 1% patients only cause rhabdomyolysis, gets rhabdomyolysis from any statin. So if it's less than, if it's about low, if it's less than 3, you can change the brand of the statin. You can stop statins for 6 weeks and restart again. Statins are contraindicated in pregnancy. It is true. It's a teratogenic drug. That's why we avoid statins in childbearing age patients. So it does not induce HMG co-reductase. It inhibits HMG co-reductase, so which is false. Statins causes secondary prevention of MI. It is the utmost important drug in secondary prevention, and also they have found out that it is a drug of primary prevention of myocardial infarction. Another one going equal to this is with the aspirin. Aspirin, yes, we all know it causes secondary prevention, but does it cause primary prevention?
No.
Very good. Excellent. Because even most of the clinicians also, they give aspirin as a primary prevention one. Very good. So better than fenofibrate to lower LDL level.
True.
Very good. Because generally, to give atorvastatin, it reduces the LDL about 30%. They can reduce. But fenofibrate, it's less than 10% only reduction of the LDL levels. So with that, they might ask you about bempedoic acid. You have to know this because it's the latest one, and there are in certain pharmacies they have although it's not registered in the country yet, they sell bempedoic acid because it is that important. In all the latest 2025-24 guidelines, they're adding bempedoic acid, lipid chronic coronary syndrome, and even next year acute coronary syndrome one also they will ask. So they can ask, people are talking about this. So bempedoic acid is the latest drug, and you have to know the action. It inhibits adenosine triphosphate citrate lyase. So if you see this pathway, it actually interferes in cholesterol synthesis, just as statins, just as HMG co-reductase, bempedoic acid is there. So bempedoic acid also, it can reduce alone about 10% of this thing, but not as potent as statins, but it is quite important. Ezetimibe, I think you all know, it causes reduction of cholesterol absorption. Sri Lanka readily we use a lot, and it reduces about 15%. Then PCK9, this is very important, especially these inclisiran and all that. PCK9 also still not, there's no light even that it will be brought here to our country yet, but people like asking about it because it is so effective, because it can, you can see here, it reduces LDL by 60%. And you don't, it's not a tablet, it's being given subcutaneous dose. Some PCK9s you give 3 monthly, some 6 weekly. So this inhibits the PCK9 protein, because this protein causes by inhibiting this, result in availability of more LDL receptors and increase LDL cholesterol uptake into the cells. So just remember these things. They can ask, they are new concept. Nobody discusses this, but they can ask in MCQs. Right. Next one, of course, very simple question, nothing to discuss about even. So I'll quickly go with that. Make a hypertension. Now this patient is having 180 by 100 on erythropoietin. So what is the probable cause? Obviously you can see is erythropoietin can cause hypertension here, and uremia can cause hypertension, right? Can sodium bicarbonate cause hypertension? Theoretically it can cause, but practically it does not cause hypertension, right? So others are false. I'm not going to go with that a lot. So next is now in an odd fashion, they can ask stupid questions like this in the exam, 1 MC. Either community medicine, something like, or they can ask things like this. So 80-year-old patient present with unconsciousness, resuscitated, and 2 hours later, his son came with an order not to intubate. What can you do? So we'll go question, but this is a palliative care type of thing. So you don't extubate the patient just because after you intubate someone, you don't extubate just because they tell that, right? So you keep the tube for the best. That is the most preferred answer. You have to explain these things. I don't think you have to know much. in your ethical this thing, you have to keep the tube for the best interest of the patient. Because what in medicine, there is a golden saying, do no harm. So first thing is it's patient's decision whether it would be tubed or not. But now you didn't know it, right? But if you are removing the tube by any chance, you are doing harm. So you can't do harm in this case, right? That is the answer. Others all may. So this is actually more or less this is an SDA type of question, right? Streptokinase is contraindicated. Atrial fibrillation,
False.
false. Background retinopathy,
False.
false. Why? Interesting, because now if they're having full proliferate, not background retinopathy, very good. If they're having proliferative retinopathy, it is a relative contraindication, because but not absolute contraindication. You can thrombolyze, but it's a relative. There's a risk is there. You can explain the risk and do. There is a risk of getting this bleeds in the eye. So it is a proliferative diabetic retinopathy is a relative contraindication. Bronchial asthma out. Any history of cerebral hemorrhage you don't give. Patients more than 75 what?
False.
It is, yeah, it is false. It is we on daily basis we do it, but it is a relative contraindications. Right? So I mean, if they're asking a good question, they will not ask this in a very broad way. They will ask clear-cut question. What are the absolute contraindications? What are the relative contraindications? So I think I have named all the absolute and relative contraindications here. So obviously, if there's a ICH at any point in time, you can't thrombolyze. And if there's a recent stroke, 3 months, you can't thrombolyze. If there is a trauma to the head within 3 months, you can't thrombolyze. Any history of malignancy in the brain, you can't thrombolyze. That's an absolute contraindicated, but relative contraindications are systolic blood pressure more than 180, history of stroke 3 months before, major surgery less than 3 weeks. It was earlier it was absolute contraindication, but now it's a relative contraindication. And non-compressible vascular punctures, pregnancy. Pregnancy, this is a very, very, very common question they ask. Pregnancy and proliferative diabetic retinopathy, but they like asking these two questions. Right. So next one is also, I think we can discuss the question for 57-year-old alcoholic, wandering behavior, recently coming to the ward. He had extensive plantar defects. Now there is some extensive plantar upgoing planters. What is the most, if someone asks you what is the most possibility here, because possible answer here is
Chronic subdural hemorrhage.
why do you think chronic subdural hemorrhage now?
Chronic alcoholic might have fallen down and more prone to get subdural hematoma and one-sided symptoms.
Yeah, so there he had the smart reflexes in one side. So why not wernicke's encephalopathy?
Wernicke's would be bilateral.
Very good, excellent. That is the only thing I want to hear. Perfect. I think more than enough. Then nothing to talk about even after that. But if it was very clearly said, if it was wernicke's, there will be bilateral ones. Generally, they can have upgoing planters in wernicke's as well, right? Because wernicke's encephalopathy, it's a generalized brain thing, right? You can have these confusions and nystagmus and ophthalmoplegias and all that. Generally, they will be diffusely involved. So alcohol toxicity generally doesn't cause thick ridges, right? Chronic subdural hemorrhage, they can present with acute worsening and they can have this type of picture. What about TIA?
Oh, possible. They haven't mentioned about a time duration.
They have mentioned over time, we never know. So TIA can come. Cerebral tumor?
Again, possible.
Again, it's possible. But the best answer here will be chronic subdural hemorrhage. Excellent. That's a very subtle point. That's what I want to do. Very good. Yeah. So I have put a few things about wernicke's encephalopathy because I want to highlight. Now we think wernicke's encephalopathy questions they give only for alcoholics. No, if a young lady, thin lady comes with features of confusion, ophthalmoplegia, cerebellar dysfunction, you have to think about wernicke's encephalopathy. Why? They can have anorexia nervosa. Other thing is bariatric surgeries. These two, don't forget these two as well, right? And of course, hyperemesis in pregnancy. Right. So next question is about, obviously you know the diagnosis, right? This is acute severe pancreatitis, right? So BP is low, patient is having transaminases, it's obvious acute. So what is the next step of imaging? This is for this is actually anybody can argue anything here.
Yeah, so the problem here is so usually we need 2 out of 3, right? To diagnose.
Yeah.
So here they just said amylase is elevated, so we don't know whether it is elevated than 3 times the upper
Three
limit.
times the upper, yeah. We'll assume it's 3 times the upper limit.
Then, sir, we don't need the CT to be done. So then the problem that I'll be thinking whether it is a stone and whether would I need to go and do an ERCP. So because of that, I'll go for ultrasound splenectomy.
Yeah. So very good, excellent. So in any ways, even if I will simply take this, I mean, that is the utmost theory that you explained, Akmal. I'm very happy about that answer. Now, because if the amylase is 3 times, is obviously in pancreatitis, nothing more to see. There's nothing to look, right? Unless you're not sure about the diagnosis. And on the other hand, see the question they are asking, what is the next step of imaging study? So, I mean, these are Sri Lankan questions, so this is not a foreign exam. No? So, in Sri Lankan setting, obviously the next exam investigation will be anywhere, will be ultrasound scan of the abdomen. No two words, it will be the ultrasound scan of the abdomen. By ultrasound scan, if they confirm only, and after, as you said, after the ultrasound scan, we will decide on whether to go with MRCP or ERCP. If there is a stone, yes, ERCP. If we are not sure, we'll go with MRCP. So those are the investigations. Both the modalities are done in our setting, right? Right. So acute pancreatitis, I assume that surgeons would have thought, right? It's basically a surgery thing more than the medical thing. From medical point of view, do you give antibiotics?
No, sir.
No, they can ask in them because you don't give antibiotics. You generally don't give antibiotics, and you have to monitor these scores and all that. Generally, pancreatitis patients, I don't know, even only I have managed pancreatitis when I was HO, house officer. After that, I haven't seen a pancreatitis patient even. So generally managed with the surgical team. I think surgery, it's there in your notes and all that. You can go and read it up. And you have to know about the complications actually. This pseudocyst and all those surgical stuff, necrotizing pancreatitis, they can get pancreatic duct strictures, and these complications are important, right? And the causes, of course, alcohol being the commonest cause. From medical point of view, I think causes will be the important thing, and scorpion bites, things like that, right? Right. So good. Any questions? So yeah, good that I'm getting, I think the number of people who are asking questions through WhatsApp has gone up quite a lot actually. Good. So anybody can ask any question. I mean, even if I'm at work, I will answer at least in the night even. So you all can ask questions or any doubts, or if anything, you all want to challenge any answer that I have said, quite always welcome to ask anything. So good, and I hope that you all will also talk, because then I know how the standards are, right? It's easy to kind of now, because if all I mean, we're not doing class, there are different set of standards, right? So if all standards, I mean, if it's a similar set of guys, then I can also kind of tell big things. So it will be easy for everyone. Right. So shall we wrap it up? Then study well your exam. I saw your exam dates are being posted, no? So we'll try to do one or two more classes before your exam, so to brush things up, and you all study other subjects as well, not only medicine, but to pass the whole exam, no? So we'll meet up next week. Sudhir will tell you all the next day. Right. See you then.
Thank you, sir. Thank you.
Okay,
Thank
bye.
you, sir.